once a month, and we have these conversations. The conversation is the most important part of our work there. It's never about just handing a kit to someone and walking away. Every conversation touches on the dangers associated with IV drug use and the various infections that one can get from using IV drugs. Although we do focus on hepatitis and HIV, we go into different infections that you can get by not having an injection site, or by different ways that sometimes people clean their needles when they use them with their mouths, and that leads to all sorts of infections that we see all the time in the hospital. So we talk about that kind of thing. We also talk about teaching people how to disinfect, and we talk about various substance abuse resources that are available. So our primary goal, though, is that the best way to prevent infections associated with IV drug use is to not use IV drugs. At the end of the day, that is the best way to not get HIV and hepatitis and everything else. However, if that isn't a reality, using a new syringe every time or not sharing works is the best option. And then using bleach in the tools that we hand out to our kids should be thought of as a backup in case a new syringe isn't, they can't find a new syringe or things like that. The kits that we hand out contain a little 2-ounce bottle of bleach, some bottle caps, an alcohol swab, Band-Aids, condoms. They're very, very small kits, but everything that one might need to protect themselves against disease transmission. I won't go into how to disinfect a syringe or whatnot for the sake of time, but if we have time later, I can do that. The second main component of our program is the medical student education that we provide, which consists of the training that we conduct for volunteers. Issues about IV drug use, infections associated with IV drug use, and the unique needs of this population are not covered in our medical school curriculum. We don't know, we aren't trained to deal with this issue at all, and we deal with it on a regular basis in our training hospital, and every single one of us is going to have to address these issues on a regular basis as doctors. So it was really important for us to do this training. And our training is conducted, we wanted it to be led by leaders in the field, so it's conducted by our dean of students, who is an internal medicine physician, and by a member of the Community Prevention Intervention Unit, which is a component of the Southwestern School of Health Professions they work with communities to create disease prevention programs. Our primary goal of the training is to teach medical students how to work with these populations in a way that is sensitive and respectful. We want to give them the verbal tools. Our training is very concrete. We want to give them the language to effectively have these conversations, which are really difficult conversations to have, and the issues are very difficult issues to address. But most importantly, a lot of medical students have never encountered someone who uses IV drugs. They've never had a personal encounter with someone who's homeless. And by creating this opportunity and giving them, pairing a face to the word IV drug user, we're hoping to de-objectify these populations and inspire med students to provide better services as doctors and advocate for these patients, which they will have. So I went up to New York and actually met with some members of the Harm Reduction Coalition to create this training, and they shared some slides with us and some information with us. But the training basically covers, again, infections associated with IV drug use. It covers basic principles of harm reduction, and it covers how to disinfect a syringe and how to perform community outreach. Again, all things that aren't covered in medical school curriculum at the moment. So far, we've been doing pre-intervention and post-intervention tests to see if this is an effective way to teach med students about these topics, and we've seen statistically significant improvements, not only in medical students' knowledge about these issues, but also in their sense of HIV and hepatitis rates remain high, hepatitis especially. The main risk factor for hepatitis C is IV drug use. These techniques, harm reduction, disinfecting the syringe, focusing on the health issues associated with IV drug use, have been shown to reduce these diseases in communities. And another reason we do this again is to prepare future physicians to work with these populations. But most importantly, we do this because we are in a really unique perspective as medical students. We don't have a religious affiliation, we don't have a political affiliation, we have a medical affiliation. When we approach this problem from a medical perspective, that there are these diseases and this is something we can do to prevent these diseases. It's a no-brainer, essentially. So from our perspective, since we can just focus on that, it makes it pretty easy for us to go out and do this. Well, while this has been a successful program as far as medical student education, we've come across a lot of barriers that ultimately have limited our efficacy. First of all, we're a volunteer program. There aren't that many of us. We only have enough volunteers to send 5 to 10 volunteers once a month to the shelter. Also, medical students don't have much time. Med school is incredibly time consuming, and so we've only been able to get volunteers to commit to 1 to 2 hour shifts at most when doing this. Also, this model doesn't support the building of lasting relationships with people who use IV drugs. And a lasting relationship between the provider and the person using is an absolute must. You must have that if you're going to get anywhere in the world of substance use and addiction and make progress toward working toward not using. So, and most of all, as of recently, last week, the shelter that we've been working with has decided to end our relationship working together as it stands at this moment. When we first started this program with them, there was a lot of excitement and support of the program and having med students come and teach guests about how to protect themselves, but they recently decided that our program and handing out these kits goes against their policy regarding not having paraphernalia for drug use on campus. So right now we're currently looking for different places to send volunteers, and I would love to hear any feedback if anybody has any in the audience, but I think this really speaks to the difficulty in starting a program like this in the political and cultural climate in this area, where handing out bleach and helping people protect themselves against diseases is a controversial issue. So, thank you.
Our next speaker with the Coalition for Harm Reduction.
Thank you for these 2 months for inviting me. My name is Frimpong. I'm from New York City at the Harm Reduction Coalition. We are a national organization of folks who are very committed to the health and well-being of people who are affected by drug use. Right. So, how many people before you came here? How many people have the term harm reduction? It's by raise of hands. Okay. So, for some of you, this is a new term that we're using. So, I'm going to give some time to give some context about what harm reduction is, and then really go into actually some of the stuff that Tessa left us off with when we were talking about, the difficulties of really implementing these programs, because in reality, harm reduction is something that we practice, even when we look outside of drug use, in our daily lives. So I really want to have a conversation about that. And because I'm all about responsive participation, and I'm really going to be talking about what's rational. I have a sign here that says the word rational. So every time that I hold this sign up, I'm going to need the audience to say what's rational. So we'll do a practice one time and then we'll get started. So 1, 2, 3. What's rational? Great. So what's rational? The very experience you rejected before with lies, you are now accepting without apology. I got this quote when actually flying over here. I was reading a book by Malcolm Song. It's called The Healing Wisdom of Africa. In the actual quote, he's talking about his experiences of his own healing coming to being as a man growing up, and realizing that many of the times when we have our elders or people who are able to guide us through life, expose us to certain experiences that we may not agree with, we think are foolish, we don't necessarily think at our best interest because we're not necessarily well informed at the time of our decisions. Very well maybe those blessings that we receive later on, but the funny thing about us is that we accept those things and do those things without any type of repentance, right? And so when we're talking about what works about harm reduction, well, yes, harm reduction works, right? And so to deepen our understanding, what is it about harm reduction, right, in the context of drug use, when we're talking about injection drug use, right, that makes this issue of exchanging needles to prevent the spread of bloodborne pathogens, providing direct access to Narcan and naloxone, right? These are medicines that can help reverse an opiate overdose, right, and can prevent overdose death. Providing substitution therapy like methadone to people who need their basic needs met to heal, right, from the atrocities of punitive drug policy. And so when we look at these things, as Tessa mentioned earlier, they're controversial, but I would also want to add, they're unnecessarily controversial for a reason. These things are made to be a political spectacle, right? Because when we talk about policies and practices, they come from somewhere, right? When we talk about our institutions. And then 3, we're looking at a zero-sum game that is based in plaguing people's lives with stigma and suffering, only to further trauma and the barriers that people have to face in order to get the basic needs that they have met. So looking at these 3 points, really get at the concept of, how people can be rational or not, right? And how easily we can become liberal in our definitions of what's rational when there are competing self-interests and agendas in a country that pushes a war on drugs with no strong promotion of an analysis of the drug trade and its implications on the health impacts among people most affected by its collateral consequences. So instead of talking about how does harm reduction work, or does it work, the simple answer is yes. I want to pose the question back on to folks to think about in looking at what's rational for the institutions, right, that develop and implement policy and practice, and then secondly, versus what's rational for the people that are directly impacted by the policies and practices that are established by these institutions, like our governments, like local health departments that may put out some of these laws in place. So we're going to take a look at needle exchange programs as an example of that. And so in looking at the history, needle exchange programs were programs that were started by people who were using drugs, who were trying to survive